Exertional lower limb pain is really common, we know that. Every study around shows something between 20% and 80% of runners in a year will have some form of exertional lower limb pain. Now those studies are obviously slightly skewed because you can't go from one study having 20% and one study having 80% without there being some problem in terms of nomenclature. And across the literature they use overuse lower limb injury, exertional lower limb pain. And then there are two conditions which are named as conditions, but I'm going to argue that they're not really conditions themselves. And one is chronic exertional compartment syndrome, and we're going to focus on that really in a second, and medial typical stress syndrome. And what I want to try and get across is that I think they're all the same. I think all of these conditions, all of these exertional lower limb pain problems are all a biomechanical overload of the lower limb. And it's not such a radical concept, because actually if you kind of think about what happens in most of these, all of the presentations are exactly the same. They're all progressive, they're all muscle pain, they all stop you running. And then usually you can stop and start again after a short break. All of similar sort of things to occupational sort of mechanical overuse of the forearm and typists. So it's not too dissimilar, even though two have slightly distinct characteristics that people have looked at. We'll focus on KEX because MTSS, but I'd argue it's the same. This thing doesn't work now because it's gone from that, but clearly, before you get to the extrinsic risk factors we're going to talk about, there are a load of intrinsic risk factors that you haven't got a huge amount of control over as the sort of clinician looking after them. We'll skip over it because it's not working brilliantly. But those extrinsic factors are really the ones that we're going to focus on in terms of the running shoe, the amount of running that they're doing, the surface they're running on, whether they've been on a chi or post running course, which I think is an extrinsic factor. If someone's read Born to Run and has decided they're going to try and run in a way that they think or interpreted that the book is, certainly in our running team, we probably see out there 5 or 6 people a week who've read the book or have been on a chi running course and therefore presenting with pain because of that, not because of what they've actually been running. They've been running perfectly well with a reasonable volume. Intrinsic factors, and this method, Kaufman, when he wrote this paper in terms of trying to decide on these two sort of factors, trying to differentiate them, I think things have moved on, and actually a better way of doing it is, as Christian wrote in this paper, kinematic, kinetic and EMG. And I think we're going to focus on some of the kinematic stuff in a second, but if you kind of think, remembering kinematic is the joint angle of movement, essentially. Kinetic is the load, and the load, that's clearly resultant from kinematics. And EMG much more focused on muscle function or muscle timing or speed of recruitment. But let's just talk about KEX. So chronic exertional compartment syndrome, first named in the 50s by a surgeon who thought that it seemed to be similar in terms of presentation to acute compartment syndrome. But there is no comparison. So acute compartment syndrome is characterized by tissue death, so cell necrosis or muscle death. And no study, despite there being hundreds on KEX, has ever demonstrated any real form of hypoxic change in the muscle. So if the muscle's not hypoxic and it's not dying, it can't be compartment syndrome because it can't be reversible. But it presents in a very similar way in terms of exertional limb pain, so pain on exercise, progressive, tight, constricting. And actually, if you keep going, and most runners will keep going, they develop foot drop, and they can develop some pins and needles and numbness. So it sounds serious, but it presents and it's really very common. It's very common in the military. And this is where my interest in it started, in the sense that we would be a tertiary referral centre. So every year, for about 4 years, I did 600 or 700 of these a year on people which are intracompartmental pressure testing. It's a mock-up, so hence there are no gloves, just in case anyone's thinking of sort of plunging ventilons into people's shins. But we had an indwelling catheter system, so rather than the sort of stab striker thing that most clinics will use because it's easy, this thing is pressure manometry. So it had indwelling slit catheters and a continuous read to a machine which was used originally to measure bladder pressures, but allowed you to do quite accurate, actual real-time manometry while someone was exercising. And we had a very predetermined protocol for military in terms of what they could do, and usually they kind of burg it when they threw it off and threw it back on. But it's pretty accurate in terms of what it's really delivering. So chronic exertional compartment syndrome, diagnosed, Pedowitz criteria in 1990, decided that anything over 30 millimeters of mercury in intracompartmental pressure was positive. And if you didn't reach that at 1 minute post-exercise, if you didn't drop below 25 or 20 to 25, that equally was positive. So assume the pressure went very high, or went a little bit high in the compartment. This is anterior tibial compartment, so tiband, and then normalised. So this is the trace from what we would get. So red's right, blue's left, and you can see up the line here that the mean pressure is 105 millimetres of mercury on both legs. So the peak pressure is 250 millimetres of mercury 6 minutes into the test. So they're massive pressures. So you kind of think, okay, so this, if it was really ischemic, given the fact that their blood pressure is probably something like, I don't know, 140 over 80, being generally fit, healthy people, this should become ischemic if it was a problem, if the compartment was too tight. So if the systolic pressure is 120, the pressure in the compartment is 250, there should be nothing gets in there. This would be fine, but this person didn't have any symptoms, so this was pain-free. So they were pain-free, and they were still reaching 250 millimetres of mercury mid-exercise. So according to this person, according to this trial anyway, that this person, the Pedowitz criteria, they have kept. And they still stay high enough, as you can see, post-exercise to again meet that 1 minute post-exercise pressure criteria, and so would be diagnostic. So after doing a lot of these and sending them for surgery on the basis of the criteria, we kind of started to figure that there probably was something that either there was a problem with the test and there wasn't, or the kit, or perhaps these pressures were less relevant than actually you thought. So we did a systematic review 2012 that looked at the normal pressures and found actually, when you look at the studies that have been done on compartment syndrome, a lot of them have used a symptomatic and an asymptomatic leg. So they've used pressures in the symptomatic leg and compared them to normals in a leg which was asymptomatic. It's not the most robust way of doing it with the research. And very few studies have looked at just general normal population, mainly because you don't want to plunge great needles into the normal legs usually. And we struggled. We tried to get a normative data set in the military, but ethics each time, because there's a risk of creating acute compartment syndrome, sticking an internal catheter in. It's always a bit of a problem. But essentially here you can see the spread, of being the black line. Even of the studies here, there's significant overlap in the standard deviation of those normative pressures. So there's a problem with the pressures and the diagnosis, so it can't make a huge amount of sense. So that was all very well and good, so we thought, well, this test's crap, what do we do now in terms of trying to do something about it? And we set up about, I want to flick over that, think about how people run, and a lot of these patients have very similar characteristics. So usually they're military, so they carry bergens, so packs. They ran in a very slightly artificial way, wearing boots. If you don't look at the way they run, they're all heel strikers, despite the fact their stride length was very short. Their cadence was actually quite slow. It was just like a slow trudge rather than an actual energetic run. So the normal gait cycle in terms of sort of hamstring pre-activation as you're nearing the sort of end of the pre-stance phase, and quad and butt action really didn't happen. It was all very much tiband and calf. So it was just, everything happened below the knee, and then it became more and more apparent that they tipped forward to counterbalance the load on the back. So it's a quirky group, but it got us to start looking at actually how people moved. Seefeld's paper on the spring mass model it's gained a massive amount of popularity, partly because of all the studies looking at the comparison between, as Christian was saying, the angular force or the kinetic force of what happens at the ankle. So we'll try to explain where the energy goes. So most of the studies looking at barefoot in particular focus on the ankle because it's quite interesting, because if you change from forefoot to rear foot, the ground reaction force and therefore the video vector changes. And so the ankle kinetics change. But the body, Newton's law says the force is going to go somewhere, so the force has to go to the knee and hip because it's got to go somewhere else. And this model is maths, it's not real, because clearly there's much more than one spring between the head and the ground. But what it suggests, the take-home message from this, is actually this concept of stiffness. So if the whole lower limb, and it assumes one leg rather than two, so if the whole lower leg is a spring, then the stiffer the spring, the more energy you've got, and therefore in that spring. And so the thing that ultimately determines speed, if you're controlling cadence, is flight time. And therefore if the stiffness of the spring is greater, then you can therefore create more upward movement as you're moving forward. The stiffness of the spring is specifically relevant to speed. I've not gone around in circles. So as the spring stiffens, there's less compression. and therefore your flight time is going to be longer per stride, which is the concept. So we thought this was quite interesting because that meant that if we try to stiffen the way someone ran, from a military point of view, we might give them slightly more flight time to cover more ground, and therefore they not be in such a dorsiflex position. So the initial video vector in a 4-foot run comes back this way. So this is resultant force for all 3 joints. It's not a singular joint. So in a 4-foot running, and the work that we're doing, we find that the resultant force is very much backwards before you, as the foot makes contact, in comparison to rear foot, where this, the resultant force rather than ground reaction force, is much more within the centre of mass. That's been consistent across all our. This is over ground running rather than treadmill running. We can't afford a force plate treadmill. We'll talk about that in a second. So what I'd argue is that chronic exertional compartment syndrome is in actual fact it's a biomechanical overload of the anterior compartment. So tibant's just working too hard. So in the people that get this, they are either dorsiflexing before the foot hits the ground, or for some reason they're working their anterior compartment too much. So rather than surgery, we focused on running re-education on them. We're just going to go through the 4 cues that we use in this group by and large. It's not quite formulated, but it partly is. So this is a guy with anterior compartment type preservation on this side, pre and post coaching. So this is one intervention. And just explaining what Andrew was saying, we only ever coach 3 cues in one session because we don't think they can take on any more than those 3 cues. We might occasionally try and keep it down to 2. We use video feedback. There's a TV screen in front of them, so they can actually look at themselves whilst they run, which isn't a wonderful option, but they can. And they get 2 views, sagittal and coronal view. It's treadmill based. We self-select the treadmill speed because actually when there's so much variance that we found if we actually just mandate 10k or 12k, it starts to make people very nervous if they're not really sure of what they're actually running on. And we use various sequences of this, but it's very head down, even though we've clopped off the head hitting. So we always start with hip flexion in this group, because actually the end result is that their tibia position and foot position change. And so we asked them to think about actually lifting up their thigh, rather than, we started by asking them to flick their heel, which didn't work particularly well. So we now ask them to just think about lifting their knee, or trying to close the angle between their thigh and their torso. The end result of that is kind of handy because it gives the knee slightly higher off the ground, and therefore in order to get the foot to the ground, the tibia is more vertical. Whereas previously, almost invariably in that chronic anterior compartment group, their tibia is outstretched. So they're by and large rear foot strikers with an outstretched tibia. So we get them to bend the knee more. What we don't get them to do is to flex their knee more. We ask them to bend the knee but keep it stiff on landing so that they don't actually then sit into it. So they're not running like Grandeur Marks, they're running much more stiff but with a flexed knee. We coach this group in midfoot strike. If you coach the thigh flexion and then ask them to actually make significant contact with the ground, a lot of them are sort of very nervous about hitting the ground hard or actually trying to stamp down on the ground, but we've not really found that much. But it's a useful coaching key to get a vertical tibia, and in this group it seems to work quite well. Then they kind of develop a midfoot strike anyway because you're shortening their stride in order to do it. So we don't really coach the midfoot landing particularly, and actually it's a little bit rear foot, a little bit forefoot, it doesn't really matter. But the end result of trying to get that vertical tibia so that they're not preloading in terms of dorsiflexion is that midfoot strike. As Christian was saying, the most significant thing really is trying to reduce the stride length, because if their heel's massively outstretched, then the sort of reinforcing point is actually shorten their stride, which automatically, to some extent anyway, flattens out their foot. In the military this is partly a problem though, because depending on how tall you are, depends on where you are in a squad in terms of running. So if you're tall, you're at the back, and so your stride length is artificially shortened, and if you're short, you're at the front because you're governing the stride of the pace of the squad. And so it doesn't absolutely work. You haven't got, in the military group anyway, you haven't got complete flexibility of this. But in our recreational group, we just focus on this anyway because it makes more sense. In terms of the magic number of cadence, we don't coach to a number, we just ask them to take 2 extra steps. Wherever they're at the moment, we take 2 extra steps a minute, and then with 1 foot, so 4 extra steps completely. And then we go from there, depends on in terms of what we see. We try to avoid them counting numbers because they've got enough to think about in terms of how they focus on it. So they come on and off the treadmill, they have a look at the stuff, they get back on, and we focus on 1 point at a time. When they're happy with the first point, we move to the second, move to the third. We try and do all that in a 45-minute session, and we don't see them again for 2 weeks. And so this might work actually. So the end result is, this is what we want you to do. Yeah. So midfoot strike, vertical tibia, reasonably high thigh lift. Makes sense. Talk about choosing the okay. And then we give them a water run program. We are really prescriptive. Commonly a lot of these patients, so we've seen about 1,000 patients or so since August last year at the sports surgery clinic in running. Most of them aren't running because they've got pain, either anterior calf pain, knee pain or foot pain. So we aim to get them doing 30 minutes of exercise. So they only ever run for a minute, they walk for 4, and they repeat that cycle until the 30 minutes is up. We ask them to think only of 1 cue per 1 minute. So initially they go out and they think about thighs for a minute and then walk for 4. And secondly they go and think about their chin position or their actual increase down in what we call them, to think about their ground reaction force. So we want to actually make positive contact with the ground. They do that. If they get through that alright and they're pain-free, they're not sore after that, then we're happy enough for them to increase it by half-minute intervals at a time, so it's 1.5 minutes, 3.5, onwards as they go. When they start digging into the 2 minutes, 3 minutes, or 3 minutes, 2 minutes take sequences, they then focus on a different cue each minute, so they're rotating around. And so then you work out the 5-minute cue. If you've got 4 cues in a 5-minute thing, then in the 5th minute of running, when they're back on their normal program, they don't think about anything, they just think about running generally, and then they recycle the cues. And we just found it's a very easy, prescriptive way of making sure they do what they're told. It'll be interesting to see though, when we start the run tech study, whether or not actually when we're asking them to think about 1 cue, whether they actually do think about it, or whether there's a noticeable change. I suspect there isn't. I suspect they just all run and just go and do whatever they all kind of want to do.
How many of those sessions are you doing a week? Like I said, you did over about 6 weeks.
Yeah, so we've got 2 physios at the moment who just do this. They see 8 to 10 people a day. In addition to this, they all do a posterior chain conditioning program. So we've got 5 S&C guys, and they all attend 1 of those a week, which is really just posterior chain conditioning. So it's initially deadlifts, and then after that, it's a bit more plyo, multi-directional work, but it varies a little bit on the group. The oldest person we've had is 80-something, 81 or 82, and the youngest is 14. 14 was a real drama because of the treadmill rather than anything else. They were fine when they got off the treadmill, but on the treadmill they were like a Bambi on ice. It was horrendous.
Are they repeating that posterior chain strengthening on their own?
Yeah, they do. Yeah. So they come once a week to us, and the guys give a program they go and take away and do 3 times a week. Ireland's a bit strange in the sense that even the national athletics program have very little conditioning. So even the sort of 16 to 20 year old cross country program would have virtually no conditioning at all, and so it's a big problem. And when we first started doing this, part of the problem was actually his strength. So it's fine actually making the kinematic changes, but they get tired very quickly. And that makes sense because you're using essentially big muscles to do big jobs, and then it doesn't cross over very well. And so they metabolically feel it's quite hard work, particularly the cadence change and thinking about hip flexion. And if they get that wrong, they become very hip flexor dominant, tip the pelvis forward. We'll talk about that in a second. And so they sort of come into this sort of hip flexor overload, which you kind of don't want to see. So if they forget to stand up or sit up, then they don't extend. Whereas if the posterior chain program is starting to get to think about what they're doing in terms of that, it works really well. They're quite a compliant group. It costs them well. The first session is quite expensive, but then the rest is very cheap. So they just come back. When they come back 2 weeks later, it's 15 minutes on and off treadmill at 5, and then it's just reinforcing the cues. and their third session is more or less elective, so they can decide whether to come back or not. Most do just for a hop on the terminal, just to make sure that they're happy.
Are they running any faster?
Um, That's a really good question. No, actually, one of the big for this ABOS group to start with, one of the big complaints we had, or the feedback from the patients was, yeah, it was fine, they were running, that was great, and they'd come back and say, yeah, but I just feel I'm not going to run fast again because it feels like I'm really sort of short. You go, well, hang on a minute, you weren't running at all 6 weeks ago. Let's not worry about actually you going fast. And so that's when we introduced the posterior chain program, which has made much of a difference in terms of trying to increase the flight time, because they just couldn't get over their head. It's like, well, it's normal, I would stride out to go past my fellow competitor. So that hesitantly, because actually a fair number of these are recreational runners, who actually when you look at them, or when I look at them, I kind of think, I'm not really sure what their real level of running is, and actually those guys are the ones who are always very competitive. Listen, we're not going to go run fast, but they haven't been running for a year. So, but the posterior chain thing's made a big difference.
So you find if you do get them to go mid-foot to forefoot, even myself when I started doing it,
Yep.
it actually makes you run faster, which
Yep.
can be hard for recreational runners because they get tired quicker.
Yep.
They feel the chest going.
Yeah, I think that's a big.
And that's why people actually start running heel striking because they're getting tired.
Yeah.
That's a good way of them slowing them down, which actually can cause a pain.
Yeah, and I think that's why we're so adamant about this walk to run program. So even if they are running 20 minutes before, we don't let them. We sort of bring them back so they graduate the chain. Now whether they do it or not, who knows?
Sorry, just to reinforce, you're giving them a couple of sessions to do outside each week. As far
The
as
running stuff,
or
yeah,
is
they
it
can
every
run.
day?
No, they run every other day,
Yeah.
or they do their session every other day. Yeah, until that 2 week point when they can go every day. It's not about the shoot. It's just to reinforce the point. So the problem with seeing that volume of runners is that you tend to then become a podiatrist or a shoe advisor, which I'm not. And I've got no great allegiance to any type of shoe whatsoever. And this is the same study. And I think this study is very good in the sense that actually I think it proves you can run any way you want with whatever's on your feet. And this is the same patient running in 3 different types of shoe with a 4-foot strike. She's a normal rear foot striker. And this is coached in 1 session, so she is actually one of our physios. And so in a normal ASICS pushing shoe. In Vibrams, but they're black unfortunately. It doesn't actually show very well on the screen, you take my word for it. She's very 4-foot. Interesting in these, you can see her vertical displacement, she bounces. And it's only in these that she bounces, she doesn't bounce in the other. I'm not absolutely sure why that is. And these are innovates. So 4-degree drop.
Do you look at the torso position if they lean forward a little bit?
Yeah, we want them almost vertical.
Was she trying to run any differently or trying to run exactly the
No,
same?
we're trying to ask her to run exactly the same in each of the shoes. So she's a normal, horrendous rear foot striker, she's not a runner.
Yeah.
And so we, in her normal shoes, which were none of those 3, we just ran through some coaching cues in terms of to get her the 4-foot, and then just tried different shoes on hers to see what had happened. It was actually for a media thing that we were doing, or that she's got used to it, so I think you can kind of, it's the same